Welcome, everyone, to our monthly Addictions Grand Rounds. Those who don't know me, I'm Randy Brown. I'm the director for the Center for Addictive Disorders at UW Hospital and our Addiction Fellowship directors for our ACGME accredited fellowship at UW and our Interprofessional Addictions Fellowship at the VA. And we'll get right to the presentation, but a quick announcement I'm fairly excited about is recruitment looks to be going well for our Addiction Medicine Fellowship in the coming year. Two individuals who have accepted positions with us that some may be familiar with. One is Alyssa Bruhlman, who did her family medicine residency here and is going to continue in an academic fellowship part-time and do our addiction medicine fellowship part-time to complement that. And then to round out that full-time position, a local internist, actually Rebecca Kellum, who's been in practice with the Dean system for several years and in Seattle at Harborview prior, has taken a position with us as well. So we're really excited to look forward to having them come on board, which will be in April, actually, of 2021, after the esteemed Dr. Alyssa Toulouse graduates from our fellowship. So excited about that and continuing in our recruitment for another position with some promising prospects there as well. So today, really excited to welcome Dr. Atleru, who I've collaborated with on a number of fronts here, who does her primary care at Forest Windsor, but also, and hospital work with UW Health as well, and has really done a lot of work in the addiction medicine space and in her own practice in primary care, as well as in the hospital setting, and has a lot of interest around substance use issues during pregnancy in particular. So excited to hear from Dr. Atleru. Welcome and thanks for coming.
Thank you, guys. I really appreciate it. I know Zoom or WebEx sometimes can be difficult, so I don't know if somebody like Matt can tell me if there are questions or just pause me if people have questions. This is meant to be a little bit interactive. I gave this talk similar talk at the State ECHO conference through the Wisconsin Association for Perinatal Care. And this is just really exciting work. And it's work that is really important and kind of augments and supports the work that you all do, I think, in terms of the continuity. So like Randy said, I still do inpatient medicine. I take care of a lot of people with substance use disorder inpatient. I appreciate the latitude I've been given. Just as an FYI, I'm board eligible, which I'm very excited about. Thank you to everybody that supported me in doing that. And then I help take care of patients and people with substance use disorder and pregnancy. I just really like working with that population. And it kind of fits my family medicine view on things. So I stay pretty busy. Like I joked with some folks earlier, this is my 9th day in a row working. We had a patient last night that one of our opioid patients had a successful vaginal delivery with Dr. Howlett. So Dr. Bethany Howlett is one of my big partners, and it's spreading in our department. So I'm very excited about a lot more people taking care of these women. I have no relevant financial disclosures, and I just wanted to put this picture here. Not because I just think it's really important to like show people, even, and I've given this to like peers and patients, and to just be like, it doesn't have to be like all like doom and gloom sad like it is in the newspapers. This is our goal, and like however we reach a goal of having, somebody be healthy and be happy is really important. So that's why I put this there, and it just really struck me. So I have a few objectives. I just really want to say it's important to identify the kind of global syndrome of neonatal abstinence, and then within that, describe what we call neonatal opioid withdrawal syndrome. That is what we specifically treat with morphine. And then describe the rationale for medical management. There's a model I think a lot of people are familiar with, and then there are 2 other models that are emerging in the care of these families. And then I also just wanted to touch on the potential long-term behavioral and developmental outcomes, because I think those are a lot of questions people have. And and some people's reticence, and I understand why, to going on medication for opioid use disorder or sharing their methamphetamine use disorder with their providers. I will say, and I don't know if everybody else feels this way, opioid use disorder, when I see it on my schedule, gives me a little bit of a sigh of relief along with alcohol use, because at least I have something to offer them. There's like very little I can offer them in pregnancy for anything else. And so it's a little bit like relieving to talk about just buprenorphine and not talk about other things, because I feel a little bit more successful with it. So neonatal abstinence syndrome, which is called NAS, was first recognized specifically in the 1970s, which is kind of when the heroin and cocaine epidemic kind of re-emerged in the setting of modern medicine. And it was low then, and then became significantly higher in the 1990s, when I think we talked about pain being the fifth vital sign, and then opioids were given out, not like candy, but frequently. Um, and so I don't know, there could be a direct correlation, but specifically NAS is withdrawal in newborns from medication or drug exposure in utero, and that includes opioids. But I just want to emphasize tobacco, antidepressants, anti-anxiety medications, prescribed stimulants, methamphetamines, cocaine, inhalants, and alcohol. All of those things can contribute to what a neonate may look like after delivery. And I think that really, I just want to really separate what neonatal abstinence syndrome is. And then the subcategory within that is called neonatal opioid withdrawal syndrome. And so this is new language. I know a lot of people refer to NAS as just like the overarching subject, and we talk about NAS in the hospital and say that we treat NAS with morphine, but in a lot of folks, we really want to separate those and say the overarching kind of tree is NAS, and then NOWS is one of the branches, and that's the branch that we really highlight. So anything, as you all know, and sorry if I'm saying things that you all know, but anything can lead to withdrawal that needs treatment: Vicodin, Percocet, heroin, methadone, and buprenorphine. And this is what I tell women, like 60 to 90% of babies have NOWS, but we don't necessarily need to treat it. We don't necessarily need to like just give them morphine and treat them. And so that's why I'm excited about giving this, just because of the newer kind of methods that we have to like identify NOWS, identify what we need to intervene with non-pharmacologic treatment. And most babies, like I said, the withdrawal can be very mild, and understand that a lot of the folks that may be pregnant on opioids, also there's tobacco, there's antidepressants, there may be meth, other stimulants, other things that may be contributing to how their infant is looking. And so again, I just wanted to identify that the signs of neonatal abstinence syndrome and the neonatal opioid withdrawal syndrome overlap. So you get a high-pitched cry, they're very fussy. Sometimes they shake and they get jittery, and you can tell that in a newborn. It's different than people. You see more kind of larger arm movements. They really have trouble settling down to sleep. They can get stuffy nose and sneezing. They yawn. The biggest thing is they just struggle with feeding, and they really can have disorganized suck. Breastfeeding can be difficult. It's really hard for the parent sometimes, and I think that can exacerbate kind of relapse and risk of relapse. They, in later stages of untreated or undertreated NAS and NOWS, they can get vomiting and diarrhea. They can get fast breathing and heart rate. These babies are very slow to gain weight. It's literally like pulling teeth sometimes. Some folks in New Mexico, Larry Lehman being one, sometimes they fortify their breast milk so that they can gain weight. And most of my infants, like, it's a struggle, and I cry sometimes. I'm just like, can this baby just please gain weight so I don't have to admit him to the hospital? So the common treatment, and I think this is still on the addiction boards, is the Finnegan scale. So this was made by Loretta Finnegan, who's a well-known pediatrician. who developed this scoring scale in the 1970s. And this has been the standard of care. It's been well validated until about 2016. And I would say most hospitals, probably a year ago, I would say 95 to 96% of hospitals around the country use the Finnegan scale. I don't know if folks can see the scale, but it talks about CNS symptoms, high-pitched crying, hyperactive Moro reflex, which is that startle reflex, fever, nasal stuffiness, sneezing, poor feeding, excessive sucking. But a lot of this is very subjective. It can vary based on the nurse that's scoring. The points are added up into a score. The individual scores are not as important as a trend over time. And so what we mean by that is we score we were like every 3 hours on a clockwork, people would go in, even let's say the baby was sound asleep, we'd wake the baby up and then score the baby. And that really didn't take into account newborn physiologic states. And so if you had 3 scores higher than 8 or 2 scores higher than 12 in a row, the babies would get sent up to the NICU for morphine. And, I just want to emphasize again, like we only treat NOWS. We don't treat neonatal abstinence syndrome with oral medications. And it's really important to understand the time frame of when newborns may be displaying withdrawal. And so opioid withdrawal in the first 24 hours is usually heroin. Now that most of the heroin is getting mixed with fentanyl and methadone and carfentanil and remifentanil, that is not as standard. Tobacco is typically the first 24 hours, and it presents very similarly. The babies are fussy, they're jittery, they're just like really cranky. And if you're postpartum and you have like a substance use disorder, it can be really difficult. Like people just want to go outside and take a break. And often these folks now with COVID are by themselves or they only have one guest. And that support network that a lot of these folks need is gone. And so like we're providing a lot of that as their peer recovery specialists or as their physicians. And so what I would say is you don't want to treat SSRI withdrawal, benzo withdrawal with morphine. And then the other flip side of that is with fentanyl and long-acting opioids and buprenorphine and methadone, the delay of onset to the actual withdrawal, it can be up to 3 to 5 days. And so we usually watch them in the hospital for 3 to 5 days. Typically with heroin, it's 3 days. With buprenorphine and methadone or buprenorphine naloxone products, it's usually 5 days. Where I trained at OHSU, we discharged them on day 2 unless they were withdrawing. I don't know if that's changed. I think it has. And so, like I said, this is the very traditional score. And again, it would most 99% of the time require separation from the parent. There are some pediatric units, which unfortunately we don't have here in Madison, where the parent, you stay in the same hospital and we just transfer the baby to the pediatric floor. And so the parent can stay with the baby. Whereas in the NICU, I think it's just a different scope of practice. There's not a lot of term newborns in the NICU. And again, term newborns, 37 to 42 weeks, act very differently than 28 weekers. And so I think that's kind of the impetus for people to decide to start looking and trying newer ways to treat these infants. So then this newer model came out. It's a more functional model. It was developed as a quality improvement project at Boston University and Boston College by a neonatologist there, and it's becoming the new kind of standard of care across the country. I don't think the boards ask about this yet, but I don't write the board questions. I don't know if somebody else can comment, but it's can a baby eat, can a baby sleep, and can a baby console? So it's physiologically looking at what an infant and a baby should be doing. I mean, that's what they do. They poop, they eat, they sleep, and then when they get fussy, they're able to be consoled. And that's that's like not to put a baby, not to like impose economics on a child, but that's kind of their job. Their job is to grow, their job is to eat and sleep and really bond with the caregiver. And they need to have sleep, they need to be able to settle down. And so I think the biggest thing that we're emphasizing with this tool is whatever parents and caregivers, we partner together and say, what are the ways that we can use to help support this infant who may experience this to eat, to sleep, and to console? And it's, can the baby eat at least 1 ounce or breastfeed well? And that's very subjective. And what we mean by that is, can the baby latch and suck in a relatively non-disorganized way? Can the baby sleep for more than an hour at a time and console within 10 minutes? And 10 minutes when you have a screaming child is a very long time. And I think this really allows a creation of a partnership with the family. And that's what differs from the Finnegan scale, is it's not somebody coming in every 3 hours on a schedule, waking your child up, scoring your child. I mean, if I got woken, I mean, I do get this too, but if I get woken up in the middle of a dead sleep, I'm going to be pretty mad and irritated and fussy. And so this is more like physiologic, like looking at how a baby is doing specifically in the hospital. And so we've had great success with this, and I really want to emphasize, and I'll talk more about this. And so kind of in-depth things is we center on how to comfort infants and their parents without the need for medication management. And how we do that and how we deliver the care is very important. And I helped the Meritor Committee with Elizabeth Getz, who's one of our pediatricians, Nina Mendo, who's one of the neonatologists, kind of develop this, is quiet, dark rooms. Like, we were waking kids up, turning lights on, make sure it's quiet, make sure it's dark, make sure that the baby is swaddled. So they actually get swaddles at the hospital. Babies love being swaddled. They floated around in amniotic fluid for 10 months. Rocking, making sure that you rock them, making sure they have small, frequent feedings. Like, some babies cluster feed at night. They like to eat every half hour, and they get really mad if they don't get fed. The other thing that we've had great success with is consulting and having occupational therapy come in and do baby massages, which sounds just as cute as what it looks like, but really that centers actually also on the parent who provides the massage, and the parent actually learns how to do the massage. The parent gets some grapeseed oil to do the massage, and it's a validated method, and it really actually calms the parent down, because it's 5 minutes, 10 minutes of them like really focusing on the touch and the bond between them and their baby. And I wish I had a video for you, but one of the OTs has a great video of an infant that really shows an infant who is receiving treatment, medication, morphine particularly, and how much difference the infant made from the beginning of the treatment to the end. The infant was really tense. The infant really was just chewing on their pacifier because they were so tense. And at the end of the massage, the pacifier popped out of the infant's mouth, and the baby just looked more relaxed. And that also relaxes the caregiver. And I think, again, this is a really high stress time for our patients. I mean, even despite COVID, I think we don't really emphasize that postpartum period enough for risk of relapse. And so those are the biggest things that we do. We have them meet with lactation. We have them meet with social work. We get a noise machine. They have like a swing that they can swing the babies in. We really try to give them all the tools that they need. And it really has changed how I like provide care, because when something doesn't go right, you already have that relationship, rather than have us all rush in, or the residents rush in and be like, we don't know who you are, we're going to take your baby away from you. Like, that triggers a lot for people, and I think we don't acknowledge that enough. And so I try to start talking about this like when they're 30 weeks, when they're 32 weeks, and I have a patient population where I can do that. But it really has like really changed how we approach care, and it's less of this paternalistic, but more of this holistic approach. And so let's say an infant's not able to do what they're supposed to do, I guess. We then huddle where we have the care team provider is usually on the phone, the nurse team or the nurse is in the room with the family. We were doing these at bedside pre-COVID, but now we're trying to limit interactions. So again, that's been tricky. And just talking with the family and saying how, we see that the infant is not eating as well, but they're still able to sleep and console. The infant is not eating and sleeping, but the infant's easy to console. Or, hey, the infant's not eating, not sleeping. We've done everything that we can think of. Like, what other things are we missing? Like, and that really allows everybody the opportunity to act as a team to care for the family. And really, the timing of the Eat, Sleep, Console assessment happens when the infant's in a naturally awake state, again, rather than on a schedule. And you want to maximize like non-pharmacologic techniques, skin to skin, if parent, is formula feeding, making sure that they keep the neonate skin to skin and feed, because that helps temperature regulate, that helps their breathing. And it really actually releases oxytocin for women as well, and dopamine, which can help them stay calm. And then, so we've done the huddle. Then we look at the infant again in a couple hours, and the infant should be awake by then. Most babies feed every 2 to 3 hours. And so just figuring out with the family when the baby's waking up, and usually gently waking them up makes them less upset than us taking off all of their blankets and waking them up. And if they're still not able to do what we call normal newborn tasks, like eating, sleeping, and consoling, then we give an as-needed dose of morphine. And that has really decreased our admissions to the NICU for longer-term morphine therapy. I think, again, because you're kind of calming them down temporarily, and then they're able to kind of reset. And then you reassess the infant again. So let's say you've done all of that and the baby's still like, I am angry. I do not like what you guys are doing to me, and I need a higher level of care. I need more care. So morphine is the mainstay of treatment for neonatal opioid withdrawal syndrome in the neonatal intensive care unit, as well as in the newborn nurseries around the country. It's cheap, but requires multiple times dosing per day. The hard part about not being in like a pediatric setting or in a hospital setting is, I think that, again, the NICU is different. The NICU is a different beast. They have very sick kids they take care of. And these babies do require a lot of tender loving care. It's harder to, like leave in and out of the NICU now as well, given COVID. People want to go smoke. People need to go to their methadone appointments. And so it's really important. And the NICU at Meriter has done a great job of supporting folks in what they need. It's just a different length of stay. So usually they can stay anywhere from 5 to 24 days in the NICU. Buprenorphine has a shorter length of stay if a parent is on buprenorphine and pregnant versus methadone. I think just because of the half-life and the lipophilicity and all of that stuff. There is emerging data to treat neonates with methadone and buprenorphine, and there was some studies done with buprenorphine sublingual liquid with a pacifier. And so somebody asked a question, and I don't know how to answer it, so I'll figure it out. We can treat infants with morphine because it's not for pain management, it's for withdrawal, and we don't have any regulatory actions around that, because it's not an adult, it's not the treatment of addiction, it's the treatment of withdrawal syndrome. And this is the mainstay of treatment, if that answers your question. But with buprenorphine, people have a lot of concerns about the ethanol component that is made in the components. Just because that can cause infants to be sleepy, it can cause liver toxicity. We don't have a lot of great data or pharmacologic data around it. It's more expensive, which is what's limiting folks from using it. I haven't seen it used as often, and other folks can chime in, but there is a shorter average length of stay. And kind of the last 15-ish minutes of my presentation, I really just wanted to talk about social determinants of health. We know a lot about medicine in the hospital for managing neonatal opioid withdrawal. We don't know a lot about long-term outcomes. We know that folks with opioid use disorder can have chronic stress, and we know chronic stress can affect development. We know that it can cause instabilities in a infant and child's life. It can cause mistrust of the healthcare system because of a parent is labeled a particular way, and you see that all the time in notes, like, this is a parent with addictive use disorder. And I think that's really hard for parents. I mean, and I think they want everybody to know about it, but I don't think they want that to always be their story. And so I don't know another way around that in terms of communicating with healthcare providers, but I would love to hear what other people have done. I think the other thing is like inconsistent caregiving. When people relapse, they usually get their kids taken away from them, and that really can affect that can totally affect development, and it fractures a family. And it's really hard to determine kind of what can we do. There's systemic racism, lack of generational wealth, lack of access to trauma-informed care, institutional trauma, like being traumatized in the hospital setting. And we're guilty of that. We are the ones that perpetrate that. And we know that BIPOC individuals are disproportionately affected. They lack comprehensive care and access to addiction care and primary care. They're more likely to be incarcerated. So what do we know, and like, where do we go from here? And I don't have a lot of answers. I just think it's important to acknowledge it. I think we can really achieve a decline in neonatal opioid withdrawal syndrome if we focus on the family unit, and everybody's unit can be different. I think grandparents, parents, siblings, and I think just, again, having those conversations while an individual is pregnant, I think, is important. I, however, will also say sometimes it's hard to hear what we're saying if you have other things going on in your life. If you are actively using, if you are either not actively using, you've got other stressors, you have to get to the methadone clinic, you're running 45 minutes late for your doctor's appointment, you know, your doctor can't see you. It's really hard. And I think this is an especially hard time in light of COVID. And I hate bringing up COVID, but I feel like we have to. And, you know, people aren't able to do their groups anymore. People aren't able to connect face to face. And I think that's really important. You know, we're not able to do groups in the hospital. Like, there are enough people where we could get away with probably doing a group therapy session. And it's harder on when it's a Zoom and everyone's like, I can't see anybody like now. I can't like get like a thumbs up or a smile or a yawn if I'm boring people. And so I think the biggest thing for me is just how do we, Ritu's giving me a thumbs up. Thank you, Dr. Bhatnagar. How can we help people when we're stretched thin too? I mean, we all are. And so I always talk about community organizations and partnering with them. And I think there's so many great organizations that we can work with. It's just, how do we get the information to patients and how do we get them help? The biggest thing that I've seen that really has made a difference for me in my practice is peer recovery. And I'm happy to say that Safe Communities, Madison-Dane County, their pregnancy to recovery program are also, their individuals that are in that program are now certified doulas. And they really have changed a lot for women. I usually do a warm handoff within the appointment. I have them sign a release, I scan it into the chart, and then I'm lucky because I just call Tanya Craigie, and then she just finds me a recovery coach, and the recovery coach and the recovery specialist just shows up at clinic with the patient, and they're able to text and they're able to touch base, and they literally are the people that can sometimes hold these people together, which is a lot of space for them to have. The other thing is they can come into the hospital, and so they can advocate for the patient because they're certified doulas. So Becky Foss and Lana Hamilton are both certified doulas, so they can go into Meriter and St. Mary's because they're part of the medical team. And that has been really important for a lot of my folks. And outside of Dane County, there's Wisconsin Voices for Recovery, who I can't emphasize enough what they do around the state. And I think, again, it's important to understand. And I know we all don't do this, but it's not just about like giving somebody a phone number. And then ARC, I think I have a bias towards because I work with them, but ARC has great services that really can support women in pregnancy and people in pregnancy and parenting. I think that's, again, the thing that we forget about. And what I highlighted before is that when we're really good as physicians and providers at treating people in the hospital, like we can do medication management, we can do a lot of different things, but the afterwards is what I worry about. And that postpartum period, that fourth trimester, really can be a struggle. And it's a struggle for me too. Like these patients are emotionally very hard. Like I've called Ritu Bhatnagar multiple times and I'm like, what am I doing? And I do it because I really want to like change these people's lives, but I want to show them that they can do that themselves. And another similar program to ARC in terms of like intensive kind of house setting is Meta House. I don't know if anybody from Meta House is on this right now, but I do know Meta House from one of my ARC patients was closed temporarily because of COVID. I don't know if they've reopened. That's something that I can look into. And then really making sure that, Dane County and each county through the school system has birth to 3. And I usually make those referrals anytime an infant's in the NICU or even with the 5-day length of stay, again, so that they can make sure we meet developmental milestones and go to the dentist. And it just is another like support layer. And again, as patients, I can't imagine like balancing like, okay, so I have to go to my pediatrician or my family medicine doctor and go to my addiction person and go pick up my methadone and do all my recovery stuff. And I have a job and I have to figure out my kids' like social work needs. And that's just a lot. And we ask a lot of people. And I don't know, I know a lot of folks in other countries, they offer nursing programs for 2 years, which is great. And we do offer that in certain counties. In Wisconsin, you have to be what's called like a first time person. You can't have any prior vaginal deliveries or C-sections. And then you get the Family Nurse Partnership Program for 2 years. Or there's the prenatal care coordination for anybody else. But the prenatal care coordination has stepped back from taking new clients in Dane County because of COVID. They're all getting redeployed. Rogers has a great program as well here in Milwaukee. I also just want to acknowledge one of our residents in family medicine who's now graduated and works up in Wapaka. Dr. Ezra Lyon, he is now taking patients who are pregnant with substance use disorder, so I'm very proud of him. He is working on changing his small 4-bed hospital, 4-bed labor floor and hospital to be more kind of friendly and change to eat, sleep, console. And then I really also think it's important for our First Nations members to connect with doula services that are focused on their community. And then again, I think we have to move forward. We have to like promote and strengthen economic support for families and promote anti-racist training and teaching and really ensure a strong start for kids and children. And I always say this to people like, I don't think we underestimate our ability in 20 minutes to like make change. And I always joke about that. Like my role in addiction is like 5%, I think. But I really wish I could do more. And I think with Eat, Sleep, Console, we've done a lot. And I think we've really kind of transformed how we can help families in the hospital. I really would like to see that approach and how we transition folks into the outpatient setting and into kind of their home. And that's the thing, is people are like, I do really well when I have structure, which is why some people like feel like, hey, jail like gave me structure, I got my meds, I had a program to do. But pregnancy and childbirth can be a very triggering time for people, but B, can be a real time of great strength and courage that individuals have. And I'm really happy that we have at Meriter and St. Mary's and UW chosen, and around the state have chosen to move towards a more holistic way. I also want to say there's a third or different way that's more a developmental pediatrics approach that does, I think, a little bit better support network for inside and outside the hospital. But I'm not a developmental pediatrician. Those, in terms of like networking and support services, those, I don't know if our organizations can sustain that. And so we've kind of moved to this Eat, Sleep, Console. And I know we can do more work, but again, I really just want to emphasize that it's been like really life-changing for women. I've only had, knock on wood, all 3 of my patients right now are pregnant and in the hospital delivering, and so I hope they don't go into withdrawal, or their babies don't, that need treatment in the NICU. But I haven't had a infant in the NICU in about a year since we've changed. And that's been really exciting, because I think a lot of parents and people get really scared still. And that's understandable. And it actually limits, I know people who get referred to me that use heroin that just don't want to go on medication because they don't want their kids to withdraw, because they're so guilty. They feel so guilty about that. And it's really hard to break that. But now that we have this way of doing things with Eat, Sleep, Console, it's slow, but I think the change in that has been really helpful. And with Eat, Sleep, Console, you can still breastfeed or formula feed or feed your baby however you want your baby to be fed. But I also just wanted to acknowledge Dr. Getz. She has been instrumental in my development here, and just really instrumental in kind of championing Eat, Sleep, Console around the state and around the region, and working with the hospital on really promoting the dyad, as we call them, but also the whoever is caring for this person, making sure that they feel like they're the most integral part of the team, because they're part of our team. This is a team effort. Child rearing is not in a vacuum. Like, we've all been, like, generations have been raised by other generations. And so I think that's what's been really important. And I've ended a few minutes early, sorry, but these are my references. And I think I sent Heather the slides, so I'm happy to share them. It was just a brief talk. Sorry, my lips are really chapped and my throat is dry. I apologize.
Great. Thanks so much, Sri. Keeping an eye on chat and for any questions, or you can also unmute and try to ask as well, and we can see how that goes either way.
So I know Glenn asked, with the Harrison Act, we can't use morphine to treat adults in withdrawal. I think because they have a known substance use disorder, but with newborns, withdrawal is physiologic withdrawal, so it's not right. Treatment of addiction. So that's kind of how I frame that.
And I can't say with 100% certainty, but I think that medication is FDA approved for that indication in this clinical setting. And that's also kind of a way around that, because some of the specific language in the statutes is actually the act in the early 70s that sort of gets at some of this by way of using controlled substances for purposes of maintaining or detoxifying someone with a use disorder. Has kind of some of that specific language in it around FDA indication. So that's why we can use benzodiazepines for alcohol withdrawal management, for example, because that FDA indication is there.
Yep.
Yeah, it's the Narcotic Addicts Treatment Act, that obnoxiously.
I think they really need to rename that, but yeah, sorry. Go ahead, Elizabeth.
I just first wanted to thank you so much for your talk, and especially thank you for bringing up some of the sort of social justice issues. one of the things you said just sort of made me reflect on something that I heard at a talk from folks from Vancouver who you probably know, but Ron Abrams and his group
Yeah.
with FUR. And I just wanted to share it with the group sort of as you were reflecting on sort of where do we go next. And something that they had said was that if we spent nearly as many resources supporting moms and families as we do putting kids into foster care, we would have tremendously different outcomes. And I think when I think about a lot of the moms I work with who have addiction, they often came up in foster care because their own families had struggled with addiction. And I often sort of reflect on that, and that plays out in addiction in a lot of ways, right? Like if we spent all the money that we spend on criminal, legal, sort of, on just actually supporting people and job training and all the other things. But I think when we think about where should we be going, that's a model that I often think about. And I had the opportunity to visit their programs in Vancouver. And it's actually not Ron's program, it's a separate program, but they have a unit in the hospital where women can live for like 3 months. And it's more like it's like a step up from a recovery home, but I mean, just the levels of support. And I think, which obviously comes from having a national healthcare system, but yeah, there is a lot of, that can be done. And it's actually great for me being new to Wisconsin to hear about some of what's already happening here. So I just want to thank you.
Yeah, I think that's the other thing. My friend works in Vancouver, and so in British Columbia, she works for, she went to residency with me and then moved back up there. But there are no restrictions on prescribing methadone or anything like that. And so that's all done in the office setting. And so they've really removed all those barriers. Katie asked a question about what have been your experiences in needing to refer mothers or family members for SUD treatment following the perinatal period. So I will admittedly say, my role is very unique because I'm family medicine, and Randy and others do this too, but I take care of the whole family. So if somebody wants to have treatment or somebody would like to learn more, they just come to me. And so I have people, like my next patient drives an hour and a half to still see me. She's one of my old ARC patients that her kid's now almost 3, but she won't go to anybody else, and which is very nice of her. I feel awful, and I ask her every single time she drives up to see me if she wants me to help her find a new doctor. But I don't know. I usually just take care of it myself, but that's not the experience for everybody else. And I think as medication for opioid use disorder and alcohol use disorder becomes more kind of permeated through primary care and specialty care, and we're doing a lot with hub and spoke here at UW. I hope that will get better. Usually what I also do is I can't all do this in a vacuum. So I usually, again, you saw Dr. Bethany Howlett. So she works in the Belleville Clinic, which is in Southern Dane County, and they have a lot of clients they have a very special rural focus. And so she's been doing a lot of great work with Dr. Landick and Dr. Lochner down there. But I call people, or usually the maternal fetal medicine docs call me and they're like, hey, we've got a patient, and we're still trying to sort all that out. There should just be an easy way to do it. Most of the time I just funnel people to Randy and Access just because there are more resources. So Caitlin Regner is one person. Dr. Regner works at Access. Dr. Lee Driesing works at Wingra. Dr. Brulman, who I'm mentoring as well, who has a special interest in this population as well. So or I call Ritu and say help. That's usually what I do. Anything else? I mean, I think the biggest thing, like everybody has said, is we all give compassionate care, but we also should take care of ourselves. And so, at the end of a long day, I mean, it is hard taking care of these folks. And my biggest thing is I try to do yoga. I wasn't as good about it the last 2 weeks and haven't been eating as healthy, but I think just making sure that you have a routine that you can not necessarily disconnect, but turn towards so that you can recalibrate and be well for yourselves. So that's all I've got, Randy.
All right. Great. Thanks again so much, Sari. Really appreciate it.
Yeah. Here, I'll end
Heather, are you on? I am forgetting our topic for our next grand rounds. Do you have that handy?
Oh, give me just a second, and I think I can look that up.
So, yeah, January 6th, again, at our usual time here at noon. But yeah, if you don't have it super handy.
Yeah, I'll send
out
something out to the group soon. We definitely have things scheduled through May, I believe. So.
Wow, wonderful. All right. Great. Well, thanks again, everyone, for coming. Thanks again, Sri, for joining us.
Oh, I see Dr. Lyon. Good. Hi, Ezra.
Hey.
So, yeah. Cool. Thanks, guys. Thank you so much.
Well,
Thank you.
Yeah, thank you.